We are live on Facebook also, on YouTube also now. I'm silent here.
Yes.
So I welcome all my audience here. Roma, you have to keep yourself unmuted. We welcome all our audience on this monthly webinar. We have started this series of once a month webinar for two reasons. One is so that myself and my fellows who are presenting the topic, they read the subject in great depth, and also we all have to become savvy with the technology. So while doing webinars, every time we come across different kinds of these problems related to technology, but we try to overcome them every time. Today, because of bad weather, it was really a difficult task to connect through with you all. Even the mobile network was going intermittently. So we are sitting in different rooms and trying to give you and serve the best to you. So those who have joined very much in time, we'll start the webinar now. Our topic selected today is all about Mullerian anomalies. We recently did a case on ACUM, which my fellows will be talking about and my students. So most of the gynecologists who are into general practice, like we all are practicing, and whatever we learned in PG, maybe 20 years, 30 years, many anomalies were not known that time. Probably we didn't even have MRI, ultrasounds so much available. So many things are evolving, and we'll get to know more and more as technology advances. ACUM is one entity which is still not known to many gynecologists practicing normal obs in gynae. So we selected this case, and we'll be presenting the case. The order of sequence of events would be case presentation followed by the surgical video, and then Dr. Bhargavi will be discussing the anomaly, and then I'll talk about classification, the recent updates in classification of Mullerian anomalies. So I welcome my first speaker, Dr. Roma Kumar. She's our second year DNB student at JP Hospital, a very bright student, and she will be presenting her the case which we did recently, and I will just share the screen for her.
Hello, good afternoon, everyone. Myself, Dr. Roma. Thank you, ma'am. I'm going to present the case.
Can you see?
Yes.
Roma, yeah. Dr. Roma is going to talk on ACUM. ACUM stands for accessory and cavitated uterine masses. Can you see the slides, Roma?
Yes, ma'am.
Okay.
So a 28 years old female, unmarried, presented with pain in lower abdomen, more on left side, since 2 years. Menstrual history, age of menarche at 14 years, and she bleed for 2 to 3 days after interval of 20 to 30 days. And the flow was average with mild dysmenorrhea, and her last menstrual period was on 20th of April 2022. Family history was not significant, and no significant past history noted. Now her complaint was patient had mild dysmenorrhea since menarche, and she was taking Meftal spots for the same, and pain was relieved. Pain was progressive in nature, and since 2 years she was having pain in lower abdomen, severe type, mainly on the left sided after each menstrual cycle, and started on the 3rd day of cycle onward and for 2 to 3 days. Pain was colicky in nature and was radiating to middle thigh and back. Pain was not associated with fever, vomiting, urinary symptoms, or GI symptoms. Pain was only relieved with high dose of analgesics. On general examination, she was of thin build and her vitals was normal. On systemic examination, there was no abnormality noted. On per abdomen examination, abdomen was soft and no palpable mass noted. PSPV was not done as he was unmarried. On investigation, ultrasound showing uterus was normal size and well-defined lesion adjacent to left corner of 1.5 to 0.97 centimeter with thick isoechoic wall and central echogenicity. And it was suspicious of accessory cavitated uterine mass or fibroid. This is an MRI pelvis report that we have. MRI report showing a small altered signal intensity lesion in left lateral wall adjoining round ligament, interlesional blood product with interlesional blood product, and findings suggestive of accessory cavitated uterine mass, also known as ACUM. Differential diagnosis was made as cystic degeneration in leiomyoma and mild indentation of endometrial cavity in fundal lesion with normal fundal suggestive of arcuate uterus. A tiny fluid density cyst in subendometrial region in lower uterine body and suggestive of subendometrial cyst. Summary. The summary was a 28-year-old unmarried female with post-menstrual cyclical lower left-sided abdominal pain since 2 years, come to OPD, and USG was advised be suggestive of leiomyoma or ACUM, and on MRI, which again suggestive of accessory, confirm our diagnosis of accessory cavitated uterine mass with query of arcuate uterus or septate uterus. Patient was booked for hysteroscopic septal resection plus laparoscopic excision of the sept. Our plan of management was patient was consulted and planned for laparoscopic resection of ACUM with the hysteroscopic septal resection. Her preoperative blood test was normal. Written and informed consent was taken, and patient was taken for the procedure. Thank you.
Thank you, Dr. Roma. You have very nicely elaborated on the subject in a very short, crisp manner. And so now you all know it was a 28-year-old female. Now I'll be sharing the video with you, video of the surgery which we did.
So volume बढ़ा देना है. बस.
So we are starting the video here. I hope you all can see.
Presenting the case of a young unmarried female of 28 years who presented to us with severe dysmenorrhea, which had been progressive for last 2 years. Her MRI suggested ACUM of 1.2 into 1 centimeter near the left corner and a septum. She was posted to diagnostic endoscopy with resection of septum. Pictures of her MRI.
I'll request the audience to please mute themselves.
See the cavity in the center.
अभी दादी भी आ होंगे. हाँ.
And this was the septum in the uterus, which was beautifully shown in the MRI.
If you all cannot hear, I will speak because it was a self-narration. Can you all hear? Bhargavi, is it audible? Aroma? Otherwise, I'll speak out. If it is not, then I'll quickly, it's a short video of 3-4 minutes.
She was posted for diagnostic hysteroscopy with resection of septum and the resection of ACUM in June 2022. Sharing with you a few pictures of her MRI.
This was her MRI report.
You can see the cavity in the center and another hypoechoic area next to the cavity.
This is the ACUM.
And this was the septum in the uterus, which was beautifully shown in the MRI.
This
is the sagittal view to show that the rest of the cavity was normal.
So cavity being normal is very
We
important.
started with hysteroscopy. And as you see, both the ostia are deep-seated. And there's a bulge in the center, which is the septum.
These are deep-seated ostia and there was a septum. Normally, septum will not become an indication for resection if she is no other problem, but girl was of the marriageable age, about to get married. So the parents were keen that this should be tackled in the same septum. This was a complete cavity achieved. So this is a fusion defect. Septum means a fusion defect. Means they've fused, but the absorption of septum has not happened. This is a typical location just below the round ligament. A bulge seen below the round ligament. You will understand why it is located here when Dr. Bhargavi explains the condition. This is vasopressin being injected. Because myometrium is quite vascular, so we can't give an infusion, otherwise she would have bled a lot. And you see this chocolate colored fluid coming out, which again confirms our diagnosis.
Such a thing you don't find in neither in addition with fibroid.
And usually these are small masses. They don't grow into very large masses because of symptoms patient sees you early.
So the incision was deeper. A typical feature of ACUM, thick fibrotic wall and can adenomyosis in the vicinity of these.
Here, this is adenomyosis tissue surrounding this endometrioid lining, and rest of the endomyometrium is normal. You don't see adenomyosis in rest of the uterus because these girls come early. Adenomyosis usually happens in elderly women. And then you excise all the mass. It is tricky because there's no well-defined margin, unlike a fibroid where you see a capsule. So all the thick fibrous tissue surrounding that chocolate-colored fluid which drained out, and you already know it is 1.2 centimeters, so you don't get too deep. And another thing, it is not connected to the cavity, so you have to stay up only. This is the tissue seen. Usually there's not much bleeding. If there's something obvious, you can just coagulate that. And a running suture. With the availability of barbed suture, the things have become very easy and simple for us also. It's not just a knotless suture. It is a suture which gives you uniform tension all over the scar, all over the wound.
It's like suturing the muscle walls together. Hence, barbed suture is a great help because it keeps the tissue full, keeps the suture tension maintained as you pull the tissue.
So single layer closure or double layer depending on the defect. The idea is to give it a good, healthy and a strong scar, because this lady, all these young girls who present with this disease, they are likely to, they have to conceive in future.
And this is the typical location of
non-availability of barbed, even polyglectin can be used, which we commonly call Vicryl, but barbed helps you because it keeps the tissue stretched.
the intramural part of the tube should not get obliterated.
When you come, because the location is near the round ligament, you should avoid taking a bite through the intramural part of the tube. Otherwise, you'll be causing iatrogenic blockage of the conval end. This is the final appearance. A very rewarding surgery for the patient as well as for the surgeon. You feel very good seeing such a nice, clean pelvis.
And histopathology confirmed the presence of endometrioid tissue, and patient remains symptom-free following. Thank you all for a very patient here.
So this was about the case, and I will be now sharing Dr. Bhargavi's presentation. One second, let me just open it. All right. So Dr. Bhargavi is has done her DGO. Can you all see? Yeah. Dr. Bhargavi has done her DGO DNB from Hyderabad, and she has joined us as a fellow, and she's learning laparoscopy. Her third month is getting completed now, so I'll share her screen. She'll be discussing the disease itself. Yeah. Bhargavi, you have to unmute. You are unmuted. Yes. And
Thank you, ma'am. So good evening, everyone. I am Dr. Bhargavi. So continuing the discussion of ACUM, accessory and cavitated uterine mass.
One second. Now it's first.
So ACUM is a condition defined by the presence of non-communicating uterine mass close to the insertion of round ligament. Typical site is it will present close to the insertion of round ligament, and it is usually non-communicating to the uterine cavity. So it is a rare Mullerian anomaly found in young women, usually less than 30 years of age. So ACUM is a subtype of uterus-like masses. These are the rare lesions that resemble the uterus both macroscopically as well as microscopically. Such masses can occur within the uterus or any other sites at any age. ACUM, these are non-communicated ULMs that occur contiguously along the wall of the uterus. So the typical site is at the level of insertion of round ligament. This is because of gubernaculum dysfunction and responsible for duplication or persistence of paramesonephric duct, leading to accessory uterine tissue.
I'll interfere here once. Bhargavi, am I audible?
Next.
Bhargavi, can you hear me? Am I audible, Bhargavi? Say yes or no. What I wanted to say was this gubernaculum is a structure which is present in the embryonic life. And part of it, which is here, this becomes the ovarian ligament, and rest of it becomes the round ligament. The part medial to the part of the paramesonephrine duct, which is medial to the gubernaculum, becomes the uterus, and the lateral part, which remains unfused, is the fallopian tubes. Yeah.
So this ACUM is a subtype of non-communicating ULM, and this is a rare newly described anomaly. Unlike other Mullerian anomalies, it is usually associated with normal uterus. So it does not match the common Mullerian uterine anomalies found in HT classification. So it should be classified as a separate entity. So diagnosis is by history and radiology. History usually presents in younger women less than 30 years of age. Next slide. So usually with history of severe progressive dysmenorrhea, recurrent pelvic pain, not relieving with analgesics. So imaging diagnostic criteria include, it should be accessory cavitated mass along the uterine wall under the round ligament. There should be normal uterus, fallopian tubes and ovaries, and the accessory cavity lined by endometrial epithelium with glands and stroma. And there should be blood degradation products in the cystic catheter. And important point is no adenomyosis in the main uterus, but features of adenomyosis can be seen in ACUM itself. So ultrasound is usually the first investigation. So it demonstrates a thick wall cystic mass with central hypoechoic cystic component or ground glass that can resemble endometrioma. So MRA confirms the diagnosis. It shows T2 hyperintense endometrial lining and blood degradation products in the cavity, and it will further demonstrate normal uterus, cornea, ovaries, which helps to rule out other lesions. So treatment, first medical NSAIDs, continuous or cyclic oral contraceptive pills, GnRH agonists can be given, but it has a partial relief with after completing the medical therapy. So next is the alcohol sclerotherapy. It is alternative to surgery, indicated when medical therapy have failed. So under general anesthesia with continuous transvaginal ultrasound guidance, insert protein force needle into the anterior vaginal wall 9 mm, then aspirate the fluid of 2 to 3 ml and send for cytological analysis and instill 99% ethanol into cavity. So the main aim is to destroy the cavity lining, resulting in inflammation, fibrosis, and finally obliteration of cavity. This ethanol causes cytotoxic damage, cellular dehydration, coagulation, thrombosis in blood studies. There was a study, Naftin et al. Used sclerotherapy as a primary treatment for 4 patients, out of which 2 had reduced pain in immediate follow-up, but 2 were required surgical resection. So currently there is no long-term follow-up data on the success of sclerotherapy of ACUM. So final treatment is the surgery. Most published cases of ACUM have been treated surgically with high success rate. So all the published cases of ACUM have reported almost complete resolution of pain, with many patients remaining pain-free until completion of follow-up. So tumor usually presents in younger females who wish to preserve fertility. Tumor resection is the main. And hysterectomy, sometimes it presents in elder women. So final surgery is a hysterectomy, which can permanently relieve dysmenorrhea. Differential diagnosis, juvenile cystic adenomyosis, usually tendency to misdiagnose. Cystic degeneration leiomyoma, unicornate uterus with non-communicating functional horn. So juvenile cystic adenomyoma, usual and ACUM, both according to history and pathology, both were same, present similarly, but in ACUM, uterus-like smooth muscle organization is present. But in juvenile cystic adenomyosis, this smooth muscle organization is absent. Cystic adenomyosis usually presents in elder women, presents with heavy menstrual bleeding, and the basal layer of endometrial tissue usually is absent, and this uterus-like smooth muscle organization absent. So compared with ACUM, non-communicating rudimentary uterine horn, And regenerating fibroids, HSD helps in differentiation. In HSD, ACUM will have normal shaped and functional true uterus. Regenerative fibroid also same. And in non-communicating, we have an isolated cavity without communicating with the true cavity. Pathophysiology, it's due to gubernaculum dysfunction. In uterine, Mullerian anomalies, this is due to failure of one of the Mullerian duct to elongate towards the urogenital sinus, while the contralateral Mullerian duct develops normally. But in cystic degeneration fibroid, this is entirely different pathology from ACUM. So it is mainly secondary to reduced vascularization, leading to tissue necrosis, creating cystic cavities. So histopathology, ACUM, there will be endometrioid epithelium like lining the cavity, and adenomyosis can be seen. And in Mullerian anomalies, same cavity lined by endometrial lining is seen, but there is no evidence of adenomyosis in Mullerian anomalies. And in fibroids, it is different, like circumscribed solid rubbery form texture. Prognosis and follow-up, there is currently limited evidence on follow-up of these patients. So future research is required on how surgical resection may affect fertility or pregnancy outcome. So thank you, everyone.
So Dr. Bhargavi, if there are any questions, they can be written in the chat box. Okay. So any questions I would like to see, we would answer at the end of this talk. So it was very informative, and so nicely you have covered all the aspects of ACUM. Now I'll be starting my video, because still in minds of gynecologists, there's always a confusion. Suppose I come across a uterus which is not very uniform. I will not know indentation. What should I describe it as? Biconvex, partial biconvex, partial septum. What investigation should I do? These are questions usually in the minds of all of us. So I will start my screen share. I'll open my screen. A lot of changes have happened. A lot of evolution has happened in the classification. One second. I'll just open my presentation. Just give me 1 minute. In the meantime, you all can type your questions if you have any. Or you can ask any questions to Dr. Bhargavi. You can unmute yourself. There was a lot of disturbance, so I muted everybody except for the speakers. All right, so I think others please can mute themselves so that, yeah. Bhargavi, you can unmute and tell me, is my slide visible, full screen?
Yes, ma'am.
All right. So Mullerian anomalies are a constellation of reproductive developmental anomalies of the uterus, cervix, and vagina in combination or alone that occur in about 3 to 6% of women who are otherwise chromosomally normal. Dysregulation can occur either in formation of the Mullerian ducts or their fusion or canalization. These are often associated with other renal anomalies like skeletal system disorders and rarely cardiac and hearing problems. Keep this spotlight on. Yeah. So first Mullerian anomaly was described in the year 1600 by Colombo et al., who reported a case of uterovaginal agenesis. Yeah. General population, you come across this anomaly from 0.1 to 3.5%. Normally, if you try to remember, infertile women, we don't come across anomalies so often. It is most of the time, it is the recurrent aborters where you find these anomalies, a unicornate uterus or a bicornate uterus with mid-trimester abortions. So the general population, the incidence is not as high. The highest incidence is seen in patients with recurrent abortions. Okay. Disparity is because there's a lot of difference in describing the anomaly, in reporting the cases. According to AFS, the commonest anomaly which we encounter is septate uterus, followed by arcuate uterus, and then the biconate uterus. The rare ones are uniconate and uterus diadelphys, and DES exposed. Nowadays, we don't see, because all those people who were exposed to DES, they are not anymore in the reproductive age group. So you don't see them anymore, the T-shaped uterus and infantile uterus. These were other anomalies. So clinically, these patients report to us either at menarche when the mother brings her that my girl has not started menstruating, that is primary amenorrhea, and she may or may not have recurrent monthly pelvic or abdominal pain. Then the second group comes after they start menstruating in the post-pubertal years when they're 18, 19, with increasingly severe unilateral dysmenorrhea or pelvic pain. So all the students who are hearing, they should remember unilateral dysmenorrhea is very, very typical of Mullerian anomaly. When they reach reproductive years, these women may remain asymptomatic. Sometimes we see septum in a woman who has, when we are doing a cesarean or a biconate uterus, remains undiagnosed throughout, or they may have a history of reproductive loss, malpresentation, or preterm deliveries. Most of these are rare, and it is difficult still for the clinicians to diagnose them. Let us brush up our knowledge to about the embryology. My fellows said that, ma'am, don't include embryology, but we said we have passed out long time ago. So many people who are quite senior might have forgotten these names. So we'll just quickly brush up. At 6 weeks of intrauterine development, the male and female genital systems are same. You have a mesonephric duct and a paramesonephric duct. The paramesonephric duct is also called the Mullerian duct, which is the lateral duct. And when there's no Y chromosome, the mesonephric duct or the Wolffian duct, this degenerates and the female organs form. In male, the AMH causes regression of disappearance of the paramesonephric duct, and then the male organs form. Dr. Gurvinder, I can see you speaking. Dr. Gurinder Mohan, please mute yourself. Dr. Gurinder Mohan, please mute yourself. Yeah.
Indications for hysterectomy. The list is very, very long.
Please try to do 2 webinars together. Dr. Gurinder, if you can hear me, I can see your mic on. Please put yourself off.
I'll
just stop some disturbing videos. Stop video. Dr. Gurinder, mute yourself. Yeah, thank you. So, coming back to this, the paramesonephric ducts develop along the lateral aspects of the gonads. The proximal part will remain unfused and they will form the 2 fallopian tubes, whereas the middle part will unite and will form the uterus. Now, we all remember that upper 1/3 of vagina, upper 2/3 of vagina forms from the Mullerian ducts, whereas lower 1/3 forms from the urogenital ridge. So this is, if you look at this depiction, it's a very simple way of describing these anomalies. There can be defects of formation, of fusion, or resorption. If you remember nothing, this slide is one which can be remaining in minds of all of us. Now, why still there's confusion about understanding the anomalies of Mullerian system? There's a need to describe, when we all clinicians see a patient, there's a need to describe an anomaly, more for self-understanding as well as for clinical correlation and explaining the prognosis and outcome to the patient. And improving technology and diagnostic modalities have led us to pick up more and more anomalies, which were earlier not diagnosed at all. And we need a universal classification system for a common nomenclature so that we all understand when somebody describes an anomaly. Hence, various classification systems have evolved over time. The first one was described in 1979 by Buttram and Gibbons. This was followed by American Fertility Society classification, or the AFS classification. This was depicted as simple drawings within each group. Advantage was its simplicity, recognizability, and correlation with clinical pregnancy outcome. However, it was criticized because it was not including the anomalies of the vagina and cervix. So this is one figure I think all of us remember from our post-graduation days, that class 6 classes are there. We always remember septum is class 5, biconate is class 4. But then there is a lot of, many of the conditions cannot be explained by AFS classification. Then came other classifications, this embryological clinical classification by Esseen and Esseen. Then this was called VQM, Vagina, Cervix, Uterus, Adnexa, and Associated Malformation System, which was described later on, which was reported in Fertility Sterility 2005. It was published. ESG did a great work. I mean, they did a very elaborate work in 2013. ESHRE is European Society of Human Reproduction and Embryology, and European Society for Gynecological Endoscopy. They formed a working group called CONUTA. CONUTA means Congenital Uterine Anomalies Group, with the goal of developing a new classification system. The concept was it should be based on anatomy, and deviations from same embryological origin should be placed in one group. For example, fallopian tube anomaly should be in one group, or it was all based on anatomy. Secondly, the AFS system started from more complex to the simpler one. We started from aplasia, then to duplication. Here, this was the reverse of it. Here, they started from the simplest one. Normal is U0, whereas the most severe ones become U5. And they kept cervix and vaginal anomalies as subclasses. So let us understand here. U0 is the first number is the most normal, and the last number is most complicated. U5 is aplastic uterus, MRKH syndrome. And cervical problems and vaginal problems have been given a subcategory. So it can be U3, C1, U3, V2, anything. So you can combine, mix and match. Nowadays we have these dresses, colorful dresses, mix and match. Similarly, you can actually describe your patient and correlate them with these pictures. A quick run through these. U0 would be normal uterus. Let us keep seeing this. This is a normal uterus. U2 means the fundus is normal, but inside cavity there is a problem. So this is U1. After U0 comes U1, where there's a problem in the cavity shape. Then came U2, where fusion defects are there, but absorption. Fusion is normal, but there's abnormal absorption, like separate uterus, partial separate uterus. One interesting thing, many times when we are doing a hysteroscopy, I think 90 to 100% of you who are seeing my video are doing it. Sometimes we describe it as partial septum. Sometimes we say it is coming too much down. Let us call it a complete septum. By definition, complete septum is the one which reaches the internal os, whereas partial is which is falling short of the cervical internal os. U3 means bicorporeal, means two bodies. Bicorporeal can be didelphys or it can be two cornu. So bicornuate, partial or complete. Hemiuterus was the term used for unicornuate uterus. And then came aplastic uterus, that is the MRKH syndrome. The best part was they made another class called U6, which is so as to keep class U0 to U5 very clean. They didn't want to put mix and match too many things. So they said U1 to U5 is clear, and anything beyond that comes in U6. So let us see this picture again. This is U6. After this, they have kept, after MRKH syndrome, one more class. But again, there were problems with this. There still case reports kept on coming. Like this was 2013, but then you see these anomalies. Mullerian anomalies without a classification. Uterus didelphys, unicornis uterus to be the bicervical. So there were so many range of anomalies. Another report which says a rare anomaly not included in classification system by AFS. Another anomaly, another report where it says that uterus is normal, but two cervices are there. So still we felt there was some shortcoming in the existing ESG classification as well. The wide range of Mullerian anomalies are still not unknown and confusing, not only to the obstetrician gynecologist, but also to others. Like how does a radiologist report it? How does a pediatrician report it? Hence the need for new ASR classification was required, for which by this time AFS had become ASRM. American Fertility Society had become American Society of Reproductive Medicine. So they have made a task force which consisted not only of gynecologists, but also of radiologists, pediatrician, and anybody and nurses who would take part in this decision making. So this is called ASRM Task Force Classification 2021. It was built on the strengths of 1988 American Fertility Society classification. So see, all of us remember that AFS classification that is deep in our heart. So they just modified the strengths of 1988 classification were used. They described the anomalies involving not only the uterus, but also the cervix and vagina. And they preferred using, rather than an ESG, we were using U3, C2, V2. Today I'm presenting, after 6 months, if you ask me what is V3, I'll have to think what is V3. So we have to be regularly learning these terms. So they said, why not describe any anomaly in great detail? That will help every clinician to understand this. So for example, there's a colleague, he can describe the anomaly as uterus didelphys, means two bodies, duplicated cervix with obstructed right hemivagina and right renal agenesis. This makes the picture so clear in my mind. And they also incorporated other anomalies. The ASRM MAC 21 classification tool was designed in Adobe software. So now everybody is in your hands, on your mobile and computer. So they said you cannot go back and searching for this. So you should have everything handy on the. So all of us can log into ASRM website and have this tool downloaded in our camera, in our mobiles. This tool is optimized to landscape layout for visualization and ease of navigation. It is best seen through a laptop or personal computer and is functional when accessed through an Apple iPad. There are a lot of pictures and images which are given for you to select. Not only pictures of the anomaly, but of MRI ultrasound, so you can best correlate where your anomaly falls, matches the best. Unlike AFS classification, anomaly categories are no longer numbered. You don't have class 1, class 2, but they are what you use is descriptive terminology. When the anomaly is one-sided, for example, right-sided, you may mark that, or you can click the small button which is there and say whether it is left-sided or in your case. A printable version of the main classification similar to AFS is available for those who don't have interactive format. So you can also keep those. There are 9 classes of Mullerian class. So now, earlier it was 6 classes, then came 7. Now there is 9 classes of Mullerian anomalies. Mullerian agenesis, cervical agenesis, unicornate uterus, diadelphys, biconvoid, septate, longitudinal and transverse vaginal septums are missing, which are quite commonly seen in clinical practice, and complex anomalies. Please silent yourself for the benefit of others. Dr. Indu, I have silenced you. Okay. Anushri, I have also silenced you. Okay.
Hello.
Doctors. After the talk, we'll have question and answers. So this is a depiction of these ASRM anomalies. You can see these pictures. So if you anomaly something like that, it is easy for us to draw a diagram also from these pictures. You can see here there's a QR code at the bottom. So you can scan this by your mobile and have the entire tool in your mobile. One confusion which confuses all of us is septate, biconvoid and arcuate uterus. And patient is very much frightened. He says, arcuate uterus, doctor, do something. We know arcuate uterus doesn't require any treatment. So here, if you see this interconval distance between the two, this is seen on a 3D film or an MRI film. The interconval distance you measure, and then the point which is the deepest part of that septum. If you measure this distance, this length is more than 1 centimeter, that means it is a septum. It is less than 1 centimeter, means it is arcuate uterus. If the angle is acute, it is septate uterus. If it is obtuse, more than 90 degrees, that means it is an arcuate uterus. If you find fundal indentation also means that is, serosal indentation means it is a biconvoid uterus. This is a depiction of this app. Here you can click on your anomaly, whatever is you are seeing. Please silent yourself. Intermittently, as a host, I have to keep checking whose noise is disturbing others. Anyways, so this is how it is described. You can go to the variants, what is closest to your patient's anomaly. You can go to similar to, sometimes there's a septum but a hemivaginal obstruction. Then you can go to presentation, that is the symptoms of the patient. Imaging, what is the best modality suited for your patient, and very soon they are going to put up images also. So they'll put n number of images for a biconvoid uterus, large number of images for a septate uterus, and something will definitely match your patient. Treatment options, medical, surgical, and or dilatation. So educational elements is each category has 5 educational elements. If you see here, symptoms indicate age at onset and typical symptoms for that particular disorder. Examination says what all examination findings you will get. Differential diagnosis, whatever is there. Imaging subpage will tell you MRI, ultrasound, HSG, what will be the best modality, and medical options like medical, surgical, or simple dilatation. Still after this, after such a wonderful classification, we were still caught up in some rare anomalies. It is theorized, by theory it is said that Mullerian ducts, as they come close to each other, they start fusing from the 11th week onwards. And the fusion starts from caudal to cephalic, means from the distal end to the fallopian tube will fuse at the last, the fundus will fuse at the end. Our current classification system for uterine anomalies is based on this unidirectional theory. And most of the 90% of anomalies you can explain by this. Still, there is a small group of patients where you cannot explain by this theory of unidirectional fusion. The Haskell case reports where fusion and reabsorption processes have some or the other mix and match, which doesn't actually fit into any of these classes. Therefore, we thought we are still lagging behind. Some of the diseases which have become very, at least awareness has come to patients, to doctors also now, because of the use of internet and sharing of interesting cases on various platforms. This is called Ovira syndrome. Obstructed hemivaginal and ipsilateral renal agenesis anomaly syndrome, also called Hernil-Werner and Wunderlich syndrome. This is a rare entity because here you have uterus diadelphys. See this image, there are two uteri in this case, with an obstructed hemivagina caused by a vaginal septum. This vaginal septum is closing this, so there's no outlet to the blood. And there's absent renal kidney, single, that same side, absent renal kidney. This can be further divided into type 1, 2, 3. So a woman may have minimal, there can be small opening, but ultimately this will lead to backflow and endometriosis. The treatment for this is, this talk is mainly on classification, otherwise these topics are meant to be discussed in full length. Here, if you give a hysteroscopic nick into this septum, this will drain and it will become a single cavity. A very simple treatment, but since we don't know your mind, I see what your mind knows. If you are not aware, you will not understand what to do in this case. Robert's uterus is another rare anomaly which people have, now we are seeing. Earlier, we would hardly know of these terms. We would not even see them in a lifetime, most of the doctors. Robert's uterus is a rare type of Mullerian duct anomaly in a variant of septate uterus. You can call it an asymmetric septum, means a septum not coming in the midline but blocking one half of the cavity, as you see in this MRI film or this schematic diagram. The septum has come horizontally. It is an asymmetrical septum, hence it is blocking one part of the cavity. So one is fully functional and other half, no, it's not actually half, it is one part of the cavity. As a result, there's obstruction to menstrual flow in one cavity, resulting in backward flow, so hematometra, hematosalpinx, and ultimately endometriosis. Patient will have again unilateral pain, severe dysmenorrhea. A rare complication can be ectopic in this one because of transmigration of sperms. Treatment would again be, once you are aware, you can just go and give a cut in the septum, and all the fluid will drain out, and she'll have a normal reproductive life. ACUM is the other rare anomaly, so we've talked about Ovira, Roberts, and ACUM. This is another anomaly which Dr. Bhargavi has nicely explained, and Dr. Roma has talked about the case which we had. So I'll not go into the details, but this is typically in young girls, as they may report very early after menstruation menarche, or they may report after a few years with increasing dysmenorrhea. To conclude, I would say there are many proposed classifications for Mullerian anomalies, and each has advantages and disadvantages. However, the wide range of Mullerian anomalies remain confusing for most of the health providers who may need to evaluate such patients. An ideal classification system would be such which enables us to identify Mullerian anomalies, enhance communication between colleagues and researchers, and ultimately improve clinical care. With this, I thank you all for a very patient hearing. And I think now I'll unmute the participants, or I'll go through the chat box. So you all can unmute yourself. Anybody who has questions can unmute.
Yeah, Dr. Jyoti, I have a question, please.
Yes.
Can you hear me?
Yes, I can. Yeah.
Yeah. So first of all, thank you very much. That was a very informative and a very interesting presentation.
Can I have your name, please? Are you Dr. Yamini, or who's speaking?
Yamini.
Yes, Dr. Yamini. Yeah, please tell. You can put your video on, please.
Yeah.
I'd like to see all the faces now. Everybody can put the video on. Yes, Dr. Yamini.
Yeah. So thank you very much. That was a very informative and a very useful webinar. And thank you for revising all our embryology. सारा full जैसे we had gotten all of it.
My student was saying, "Madam, embryology क्या करना है? सबको मालूम है." I said, "नहीं, please. We are 20, 30 years old. We have forgotten."
Exactly. That was the icing on the cake in this webinar. So I have a question. We had posted a case for laparoscopic tubal ligation, and when we peeked in, and this was a woman with a normal obstetric history, previous cesarean one, but she didn't have any records available, so we didn't have any notes available for her. So when we peeked in, we found one side tube and we ligated it. On the other side, we didn't find anything, and there was no history of self-injectney for previous ectopic or anything. So, I mean, I don't know, from the picture that you have shown, I couldn't zoom and see properly. It looks like probably a uniconduit one. And to repeat, obstetric history was absolutely normal. It was just chance finding. So, how would you, what kind of anomaly would you call this as? Just one side.
Yeah, one side Mullerian duct had not formed probably. So unicornate uterus can be either absent Mullerian duct or hypoplasia, aplasia or hypoplasia. Hypoplasia would have formed a rudimentary horn. Once that rudimentary horn comes, the question is the horn communicating or non-communicating? If it is communicating, it is fine because all the blood will come through the main horn. If it is non-communicating, still there are two questions. Is the endometrium lining functional or non-functional? If it is just lying non-communicating with non-functional lining, it will not cause any problem. But if it has a functional lining, every month with hormones, the blood will start accumulating. Such hormone needs to be excised as early as possible before she goes into backward flow and endometriosis. But in your case, probably it was aplasia of one duct. But it is important to finally nicely have a look because if she come and this her one uterus horn probably had good capacity, so she could carry on with her pregnancy. Otherwise, they come with repeated abortions, and so that was very interesting finding. And
Thank you so much.
pleasure to have you. Any other questions in the chat box? It is a congenital defect while presence late on immediately after menarche. One question from Dr. Vandana Sharma. Is ACUM classified in ASHRAE and ASRM classification? Dr. Yukti has asked. Dr. Yukti has asked, is the ACUM classified in ASHRAE and ASRM? In ASHRAE, they have added a category U6 where they say others. In ASRM also, if you look at those pictures, it is not, they are not talking of any class 1, 2, 3. They are saying everything you describe. So here we will describe ACUM as, we can describe it when you look at, when you go to the tool, you will find a lot of pictures which will be similar. The very USP of ACUM is very close to the round ligament, a bulge, and when you give it a nick, a chocolate colored fluid comes out. Before doing the surgery, in your ultrasound also in MRI, you will find that endometriosis type of dark colored fluid, whatever signals it will show. That is the location very a bulge, small bulge near the round ligament more than 1 centimeter is very typical of ACUM. Second question from Dr. Vandana is it a congenital defect? Why it presents late and not immediately after menarche? All Mullerian duct anomalies, they will show, of course, except for absent uterus, which may be picked up in an accidental ultrasound earlier. But all others, when she starts menstruating, then the mind moves towards this. One second, I'll mute somebody's horn is honking. So when she starts menstruating, the blood will start accumulating. So then she will start having symptoms of pain. That will be the first time she'll be brought to the doctor. In ACUM, it is a small defect, so it doesn't happen that in the very first 2-3 years she will have so much blood that she will come with pain. A girl, when I was talking to my colleagues in the hospital, one of my seniors, Dr. Poonam is here, she's from RML Hospital. She reported a case of 17 years old and who came with severe pain, whereas our patient was 28 years old. So gradually her pain had been increasing. For 5 to 6 years, it had become more. And for last year, she had to take injectable, otherwise it would not go. Rather, Dr. Poonam reported that she had planned to do a cesarean for this patient, but she went to her village and somebody delivered her normally, and she had a 3.5 kg baby delivering normally after ACUM surgery. So we come across these cases and we realize that ACUM is a small defect. If you've closed it nicely, you may decide about doing the cesarean or not.
Thank you, Dr. Jyoti. Thank you so much.
Yeah. Any queries? And because we were, and one more thing, we will be doing these once a month webinar, but we'll be very particular about our timings. I am very clear, if I'm the only listener, I will log in at 4 o'clock and I'll start. So anybody who wants to log in time, because we are not too much into introducing and meri friend hai, teri friend hai kinds, we would, because your time is very precious with so many webinars happening back to back. We want, when you log in, you should get material which should benefit you in your practice. And my fellows also, they have worked really hard to read one topic. They have to prepare themselves for many possible questions. So I hope I have given, and we also have fellowship programs ongoing. We have Fogsi training coming up from 1st August onwards. Anybody who's wanted to do 6-7 days and 2 weeks Fogsi programs, they can contact us directly. And thank you so much for being there. What is the incidence of ACUM, Dr. Vandana? The reports, people usually don't report actually. People who are doing a lot of work, see, till I didn't have my fellows, I did not have time. I might have seen cases which so very few cases have been reported. We cannot say the incidence right now for ACUM, Robert's uterus, ovida. One interesting fact I would like to tell you, there's a colleague, not to name her, there's a court case going on because they did a hysteroscopy, which any gynecologist, all of us are doing, 90% are doing. They did not see any anomaly. She used to have a lot of pain. And they did whatever best they could and they came out. Or probably they did a hysterectomy. I'm not very sure. I don't remember the case. And the case was filed and it turned out to be ovida syndrome or Roberts. So they were like, why was she not aware? she cannot be put against as negligence because this is a very rare disorder and not so much knowledge about
ಇಲ್ಲ
it.
no she's not coming.
But with passing
Sugar
time,
controlled ಅಲ್ಲ.
we all need to
Okay.
know more
And
more
money is not ready.
keep on
Another thing.
listening to these webinars. That is why they educate you. So incidence, I cannot say how much is the incidence. And I'm getting few messages for the program being informative. Thank you all so much for your feedback. And I think it's still 5 minutes. If any questions, we would love to answer. Dr. Vishakha, I can see you, my previous fellow. It is nice to see you on this platform. And some of my old fellows are there. Padmaja, you have also been with us. Vandana. I think Dr. Padmaja. Yeah, hi, Dr. Padmaja. Good to see you. I think we all are fed up with so many webinars happening. Sometimes we mark it in a calendar and then we forget, because even if we want to hear, not fed up actually, there are so many, but time constraint is there. So this program will come live on YouTube, and so that all those who have missed can always watch. Shanti Negi, I can see your name also. They have all been with us in different forms, sometimes in Fogsi training or other training programs. Many have done the online training. Dr. Selvi, many names I can see. Shanti, I would like to see your face. Dr. Yamini, it was nice. She's a consultant. She's at Safdarjung Hospital, and she's looking after family planning. Dr. Neeta is a senior consultant with a lot of experience in South Delhi. They've all taken out time. Are you writing notes, Dr. Neeta? I think we bring this meeting to an end, and it was a pleasure seeing you all on this platform. See you all. I'll keep you all posted about my next webinar.